Well, we've made it all the way to the lecture on acid-base homeostasis. Over these last several lectures, we've talked a little bit about how the body maintains a stable pH using the lungs and the kidneys. But now we're going to talk specifically about how that happens. And this is one of the lectures in this course. Actually, I think all of the lectures in this course have real clinical relevance, but you'll be encountering as you go on to clinical rotations and ultimately, especially if you're doing inpatient medicine or pediatrics, emergency medicine or intensive care medicine, you'll be encountering these illnesses and conditions where people's acid-base balance gets out of whack. And we understanding how that happens and how the body tries to correct for it is extremely important. So we're going to talk about respiratory and metabolic acidosis and alkalosis, when they happen, what are the situations that make them happen, and then the compensatory mechanisms. So when we have a condition of pH out of balance, the kidneys and the lungs work together to try to correct, to compensate. So that's an important set of mechanisms to understand. This lecture is going to be talking somewhat about laboratory results, and some of them, if I expect you to understand or remember a value, I'll let you know. And then finally, there is a concept called anion gap, and the anion gap is important for understanding or diagnosing the cause of metabolic acidosis. So let's start with just some very big picture stuff. If an individual is not breathing well, if ventilation is poor, they're not moving much air, then carbon dioxide accumulates in the fluid, the plasma and the extracellular fluid, and that dissolved in water creates carbonic acid, and that reduces the pH. And when that happens, we call it respiratory acidosis. So hypoventilation, poor ventilation, excess CO2 dissolved in water making carbonic acid causes respiratory acidosis. One way that we can fix respiratory acidosis is to improve ventilation, and we can do that using a ventilator to increase ventilation and reduce carbon dioxide. On the other hand, sometimes we have a condition where we lose excess carbon dioxide. That can happen from hyperventilation, and sometimes when people have panic attacks and hyperventilate, this happens. But also it can happen if somebody is being overventilated on a mechanical ventilator. And when that happens and there's too little CO2 and therefore less carbonic acid than normal, it's called respiratory alkalosis. Similarly, sometimes metabolism becomes anaerobic, producing abnormal acids like lactic acid. And sometimes we make something called keto acids when fat is being used as a fuel instead of glucose. And these are metabolic products, products of metabolism, and so therefore this condition is called metabolic acidosis. In addition, if acids are ingested or substances that form organic acids are ingested, that is called metabolic acidosis. It's treated in different ways, but one of the ways in which it's treated in people whose pH falls very low, like 7.0, where we're getting close to incompatibility with life, we add bicarb to IV fluid. That should be IV fluid, and I'll fix that in the PowerPoint. On the other hand, sometimes we lose excess hydrogen ions. One example is when somebody is vomiting. Another is when a condition happens that causes hydrogen ions to move into cells. And a third is when there's excessive loss of hydrogen ions in the urine. And when any of those things happen and pH goes up, that's called metabolic alkalosis. So, in order to keep pH within this very narrow range around 7.4, at which all of the chemistry that's going on in your cells works, the lungs and the kidneys work together to try to adjust and return pH back to normal. And this is called compensation, and it occurs in respiratory acidosis and alkalosis and in metabolic acidosis and alkalosis. So over the course of this next lecture, this next several slides, we're going to talk about what sorts of conditions beyond what I've just talked about produce respiratory and metabolic acidosis and alkalosis, how we use laboratory values to identify the conditions, and then how the lungs and the kidneys react and try to correct the acid-base abnormalities. And I'm going to tell you now that this is something that having a good understanding of will actually really impress clinical preceptors and help you on clinical rotations, particularly on inpatient rotations. So surgery rotations, inpatient internal medicine, inpatient pediatrics, and even the emergency department. If you have a good understanding of these conditions and what's going on, and are able to answer questions about them from your preceptors, you will prove your knowledge and your competence. We've all taken chemistry, and pH is a logarithmic function that we use to express the concentration of hydrogen ions. It's minus log 10 of the concentration of hydrogen ions, so it's logarithmic. You all know that as we increase hydrogen ions, we decrease pH. So normal pH is around 7.4, and we will make it easy and say it's between 7.35 and 7.45, but it's even a little bit narrower than that. If pH is lower, that's acidemia, and if it's higher, that's alkalemia. And again, narrow range of compatibility with life. If you get more than about a half of a pH degree away from 7.4, you are getting very close to death. So 6.8 to 8.0. Remember 7.4. Recognize that if you saw a pH of 7.3 or 7.2, it would suggest acidosis. A pH of 7.5 or 7.6 would be alkalosis or acidemia or alkalemia. Within the serum, there are buffers, also in the intracellular fluid and in the urine. A buffer is a mixture of a weak acid and its conjugate base in solution. And it helps a solution to resist changes in pH. In the extracellular fluid, the main buffers are bicarb, bicarbonate, which is the ion that we measure as CO2 on a laboratory test, and it is produced by the combination of CO2 and water, as you all know. So bicarbonate, an anion, is one of the main buffers in the extracellular fluid. Phosphate is the other. And buffers work very quickly, and they do help to keep the pH from changing rapidly. In the intracellular fluid, organic phosphates and proteins function as the buffers, and hemoglobin is a buffer in red blood cells. And because of the time that it takes for charged hydrogen ions to get into cells, it's not going to happen easily because these charged particles aren't going to make it across that lipid membrane. This is a slow process for buffers, for intracellular buffers, to buffer hydrogen ions. There are mechanisms in cell membranes that allow the exchange of a hydrogen ion for a potassium ion. So if this happens, that a hydrogen ion is driven into the cell, generally a potassium ion leaves because you can't keep adding positive charges. We have to balance charges. And that means that potassium that was intracellular ends up in the extracellular fluid and is lost in the urine, which depletes total body potassium. So in acidosis, acidemia, as the body is attempting to buffer the hydrogen ions, and some of that buffering is intracellular, we lose potassium. The respiratory acid-base disorders that we're going to talk about have renal compensation mechanisms, and the metabolic acid-base disorders that we're going to talk about have respiratory compensation mechanisms. So every day we make a lot of hydrogen ions, about 50 milliequivalents a day in our world with high protein diets. So protein metabolism results in the production of hydrogen ions. And all of the hydrogen ions that we make during a day, just like all of the excess salt and water that we bring in during the day, all of the hydrogen ions that we produce during a day need to be excreted by the kidney. There are some medical conditions in which hydrogen ion production is increased. In diabetics, because of the inability to use glucose as a fuel, the insulin is required for glucose to be moved into cells, and so we begin metabolizing fatty acids and some ketogenic amino acids and produce beta-hydroxybutyric acid and acetoacetic acids, and they get buffered to a point, but that buffering can be exceeded. We can get to the point where instead of buffering and slow changes in pH, we overwhelm the buffer. In people with chronic renal disease, if they continue to eat a high protein diet, they're unable to excrete their fixed acid, this daily production of hydrogen ions. And again, to a point that can be buffered, but we can overwhelm the buffer. And just the clinical point here is that people with chronic renal disease, particularly people with severe renal disease and people on dialysis, a low protein diet is recommended to try to reduce the amount of fixed acid that needs to be eliminated. There are some toxins that can cause organic acids to accumulate, and we'll talk about them a little more later, but aspirin is one. So people who use excessive aspirin or who overdose on aspirin will have excess hydrogen ions. And methanol, which is an alcohol which is sometimes in moonshine, it is a poison, and its poisonous effect is that it produces excess hydrogen ions. And any of these things, renal failure, diabetes, ingestion of some of these toxic substances can result in metabolic acidosis. Now, there are a number of things the kidneys do to influence pH. And we talked about some of them as we were quickly going through, but we're going to get a little bit more specific now. We talked a lot about how the bicarbonate ions that are filtered are reabsorbed. And in fact, almost all of the bicarb that is filtered is reabsorbed. It's only in cases of pretty severe metabolic alkalosis where there's just way tons of bicarb that some of it is excreted or eliminated in the urine. We talked about how the kidneys can excrete hydrogen ions. And there are a couple of ways that that happens, and we'll go into a little more detail. But those hydrogen ions that are put into the lumen um, are traveling with the buffers in the urine, which is mainly phosphate, particularly late in the tubule because the bicarb has been largely reabsorbed. The kidneys can also excrete hydrogen ions, fixed acid, as ammonium. And excessive production of hydrogen ions, or the inability to eliminate hydrogen ions through the kidneys leads to metabolic acidosis. The opposite, metabolic alkalosis, occurs when there's an increase of bicarb or a loss of hydrogen ions. So sometimes we have excessive bicarb and sometimes we lose lots of hydrogen ions in the urine or through vomiting. And when those things happen, we get metabolic alkalosis. So if bicarbonate is the most important buffer in the extracellular fluid, it's really important to hold on to it. So we reabsorb virtually all of the bicarb that's filtered at the glomerulus, and much of it is reabsorbed in the proximal convoluted tubule. And we touched on this, but just briefly when we were going through the proximal convoluted tubule. And it uses active transport and secondary active transport. And it involves carbonic anhydrase on the brush border of the lumen. So there is a sodium ion hydrogen ion countertransport in the lumen of the proximal convoluted tubule. Sodium moves into the cell down its concentration gradient, and hydrogen moves into the lumen where it combines with the bicarb under the action of carbonic anhydrase on those villi on the brush border to make it's carbonic acid, which then dissociates into carbon dioxide and water. The carbon dioxide, if you remember, can freely diffuse across cell membranes. So the carbon dioxide diffuses into the cell and combines with water inside the cell with carbonic anhydrase, and that catalyzes this reaction in both directions to make carbonic acid inside the cell that now again dissociates into hydrogen and bicarb. And the bicarb is reabsorbed on the basal side of the cell by a sodium bicarb cotransporter. And there's also a countertransporter between bicarb and chloride. So on the basilar side of the cell, the bicarb leaves the tubular epithelium cell and enters the extracellular fluid compartment, the interstitial fluid, where it is then picked up by the capillary and transported away. But the hydrogen ion stays in that cell and it just recycles, go back to the top. The hydrogen ion moves out of the cell into the lumen as a sodium ion goes down its concentration gradient into the cell. The hydrogen ion combines with bicarb. The carbonic anhydrase separates it into CO2 and water. The CO2 diffuses into the cell where it recombines with water and dissociates into a hydrogen ion and bicarb. The bicarb is reabsorbed and the hydrogen ion recycles. So there's no net loss, even though at the proximal convoluted tubule we are putting hydrogen ions into the lumen. We are simply recycling hydrogen ions. There's no net loss of hydrogen ions. And here we have a diagram showing this. It doesn't have the chloride counter transport, does it? Maybe it does. But we have the lumen. We have hydrogen ions exchanging with sodium ions, with the sodium going down its concentration gradient. We have the carbonic anhydrase enzyme combining the hydrogen ions with bicarb to make H2CO3, which now goes back to water and CO2. The CO2 diffuses into the cell where it again combines with water under the action of carbonic anhydrase, dissociating back into hydrogen ion and bicarb. The bicarb then leaves the cell through a pump. The bicarb plus sodium goes out, so sodium bicarbonate and hydrogen ions come in. And there's no net loss of hydrogen ions. So I said 99.9% of the bicarb is reabsorbed. The only time that this doesn't happen is when the bicarb concentration is so high that we overwhelm the mechanisms that cause the reabsorption of bicarb. And so if that mechanism is saturated, then some of the bicarb is excreted. And this is helpful in metabolic alkalosis. So even though metabolic alkalosis, we tend to think of respiratory compensation, the kidneys help too, because this excess bicarb stays in the urine and is excreted. Now, I mentioned the excess hydrogen ions that we make every day as a result of eating protein, and we have to excrete it. And there are two ways that we excrete it. One way is called titratable acid. There is this occurs mainly in the distal convoluted tubule and the collecting ducts, and there are specific cells between the within the tubular epithelium that are called intercalated cells that have a mechanism. They, on the luminal side, they have a pump which uses ATP to pump hydrogen ions into the urine, and that pump, that those hydrogen ions then combine with phosphate, which is the main buffer in the urine, and are eliminated, are excreted. On the blood side, we have our sodium potassium ATPase, and within the cell, this hydrogen ion allows for the production of one bicarb ion because of the carbon dioxide and H2O and carbonic acid and H2CO3. So we have the carbon dioxide is excess acid. Remember, we have carbonic acid out here, carbonic anhydrase dissociating it to CO2 and water. CO2 can come into the cell, recombine with water, dissociating into hydrogen ion and making bicarb, which is then sent back out of the cell. So we have a little bit of extra bicarb being made. The second way we get rid of fixed acid is as ammonium. So in the proximal convoluted tubule and in the thick ascending loop of Henle and in the alpha intercalated cells in the collecting tubules and collecting ducts, we have mechanisms that allow us to take ammonia that is in the lumen and combine it with a hydrogen ion, and that creates an ion, NH4 ammonium, which is not lipid soluble, stays in the lumen, and is excreted. This also replenishes the bicarb buffer because a new bicarb ion is added back into the extracellular fluid. So I was talking about different ways that the respiratory system can affect pH. And we discussed these during your pulmonary module, that when we retain CO2, that can, with the action of carbonic anhydrase, create hydrogen ions, increasing hydrogen ion concentration and decreasing pH. And when we have poor ventilation and we have excess CO2, that happens, and that's called respiratory acidosis. But when we have excessive ventilation and decreased concentrations of CO2, we have fewer hydrogen ions created, and that is a condition called respiratory alkalosis. Excuse me, but my dog is trying really hard to make me pet her. So there's compensation. The first way that the body tries to control pH is buffering, but then there are responses that attempt to normalize pH by compensation. Typically, if there's a metabolic problem, then there will be respiratory compensation, changes in ventilation to try to control CO2 levels and return the pH back towards normal. Never too normal, but towards normal. When the problem is respiratory, then the kidneys adjust hydrogen ion excretion and bicarb production and reabsorption, again to try to to return the pH back to normal. So I'm going to give you an example of respiratory acidosis with renal compensation. When we have patients who have COPD, they often have very high CO2 levels chronically, but then when they develop respiratory failure, they get pneumonia and suddenly are knocked back even further. They can acutely have higher CO2 levels and develop respiratory acidosis. So this patient has a pH of 7.1. It takes a while to get that low because of buffering. And we can look at bicarb levels in the lab to see whether this is an acute or a chronic problem, because when it's acute, you get a modest rise. Over time, chronically, you will get a larger rise in CO2 levels. It takes hours to days for the kidneys to kick in and get rid of more titratable acid and fixed acids, so hydrogen ions that are buffered by phosphate and ammonium. And this brings the pH back up some, not to normal, but some. Why does it take time? Because this requires the kidney tubular cells to make more pumps and channels and co-transporters and countertransporters. You have to ramp up production of those proteins. In addition, when we have respiratory acidosis, the kidney makes more bicarb to try to buffer more of those hydrogen ions. An opposite example is metabolic acidosis with respiratory compensation, and this is something some of you may have seen, When we have a patient with type 1 diabetes who develops diabetic ketoacidosis, they're making lots of extra fixed acids because of those keto acids that are being created by metabolizing lipids instead of glucose. And the kidney's ability to eliminate the hydrogen ions is limited. It's exceeded. So hydrogen ions build up and pH goes down. Initially, of course, there's buffering, which slows the change in pH. But once that's exceeded, the respiratory system kicks in and changes ventilatory patterns. So increased tidal volume, deeper breaths, and that lowers the partial pressure of carbon dioxide, and that raises pH a little bit, not all the way to normal, but some, and that's respiratory compensation, and it happens relatively quickly. If any of you have ever seen somebody in the truck or in the emergency room with diabetic ketoacidosis, they are often breathing quite heavily. It's called Kussmaul's respiration, and it is one of the physical signs of metabolic acidosis, particularly diabetic ketoacidosis. So we do a lot of laboratory tests when we suspect acid-base disorders. Among the things that we test are electrolytes and a test called a BMP, or a basic metabolic panel, tests sodium, potassium, chloride, bicarb, which is often reported as CO2 because it's measuring the bicarbonate ions, the carbonic acid, and the dissolved CO2, along with BUN, creatinine, and glucose. So that's a Chem 7, or a basic metabolic panel. And it is a commonly done test. And we look at the bicarb level. We do arterial blood gases, and we look at the arterial partial pressure of CO2 and the arterial pH. And this is where we measure pH on an arterial specimen. pH can be measured on a venous specimen, but it's much more variable and less reliable in terms of diagnosing metabolic acidosis or alkalosis. So using these values, the bicarb level on the BMP, and then the CO2 level, the partial pressure of CO2, and the arterial pH, we can diagnose acidemia or alkalemia, and we can figure out whether it's respiratory or metabolic. And we can also see whether there are the mechanisms of respiratory and renal compensation taking place. We compensate for respiratory acidosis when CO2 gets high, and that should be CO2, not CO plus. So if CO2 builds up as a result of poor ventilation or obstructive disease, chronic obstructive pulmonary disease or asthma, there will be increased hydrogen ions from the carbonic acid. Much of it will be buffered. Some of the buffering is extracellular. If there is time, some of it is intracellular. You remember that if the hydrogen ions move into the cell, the potassium ions move out of the cell. As there is higher CO2 levels, we're going to make more bicarb because of carbonic anhydrase making the carbonic acid dissociating into hydrogen ions and bicarb. So bicarb actually goes up, even though this is an acidosis. And then the kidneys compensate, again, slowly, hours to days, by excreting hydrogen ions as fixed acid, buffered with phosphate in the urine or as ammonium, and also by creating more bicarb, returning the pH towards normal. Now, I want to talk about a clinical concept we call the anion gap. Clearly, in any compartment, we have to add, all the charges have to add together to be neutral. Again, on the very tiny levels, we can have changes or differences electrically, but in the bigger picture, everything is neutral. So anions have to equal cations. And when we do blood work, and we do that basic metabolic panel, the main cation that we're measuring is sodium. There's potassium too, but if you remember, sodium is going to be about 140 and potassium is going to be about 4. So sodium is the big player here. It's the main cation. And the anions that we're measuring are bicarb and chloride. When you add together the anions and you subtract them from sodium, there's always a gap. There's a number that represents unmeasured ions because there are other ions. There's phosphate, there are other things, proteins, citrate, sulfate, and that's normal. We use a formula that ignores potassium. So the formula for computing the anion gap is sodium minus the sum of bicarb and chloride. And the normal range, a normal anion gap, is 8 to 16 milliequivalents per liter. A normal sodium is about 140. A normal bicarb is about 24. A normal chloride is around 100 or a little higher. And so 139 minus the sum of 24 plus 104 is 11, which is a normal anion gap. In metabolic acidosis, bicarb is going to be low. If there are anions, that excess unmeasured anions, then the anion gap will be high. In a metabolic acidosis where the anions that are replacing the bicarb are chloride, then there's a normal anion gap. So there is a non-anion gap metabolic acidosis, or if we have excess unmeasured anions, then we have an anion gap metabolic acidosis. This is only important in metabolic acidosis. So as an example, well, several examples here. Anions that are organic anions include things like keto acid, which occurs in diabetes, lactate, which occurs sometimes with excessive muscle activity in an anaerobic state, so somebody who runs very long races, salicylate, which is aspirin, acetylsalicylic acid, and formate, which is a result of methanol poisoning. So any of those excess organic anions accumulating will cause these are all things that cause acidosis, but the organic anions that were paired with the hydrogen ions, so the base side of the acid compound, the anion side of the acid compound, will first offset some of the decrease in bicarb. So bicarb goes down, but there are these organic anions. And here's an example. In DKA, sodium may be normal, may be low too. We'll talk about that at a different time. But 140, chloride 102. But if we have a low bicarb, which in a BMP is called CO2, of 18, then we'll have a high anion gap, and that suggests unmeasured anions, and in DKA, they are probably keto acids. So if you see somebody with a metabolic acidosis and they have an anion gap, they have an abnormal high anion gap, it suggests that there are unmeasured anions, and there is a mnemonic that is pretty universal to help people remember the common causes of an anion gap metabolic acidosis. So methanol, because the liver is not prepared to metabolize methanol, and formic acid is one of the byproducts of methanol metabolism. Uremia or chronic kidney failure, so excess uric acid. Diabetic ketoacidosis, keto acids. Propylene glycol or poisoning with antifreeze. The I stands for a bunch of things: infection, iron poisoning, isoniazid, which is a drug used for tuberculosis, and inborn errors of metabolism. L for lactic acidosis, E for ethylene glycol, again a chemical that is used as an antifreeze, and S for salicylate, so it's mud piles. Mud piles. Sometimes mud pies, but the lactic acid in there helps me. So let's review. Respiratory acidosis is defined as and this is with results from a blood gas. If you do a blood gas on somebody with a respiratory disorder and their arterial partial pressure of CO2 is greater than 40, that's hypercapnia, and it's caused by hypoventilation, a decrease in ventilation. If the partial arterial pressure of CO2 is less than 40, that's hypocapnia. So you want your partial arterial pressure of CO2 to be around 40 as normal. And the cause of respiratory acidosis is this is backwards. That should be respiratory. No, it's not backwards, but this is respiratory acidosis. This is respiratory alkalosis. And the cause is an increase in ventilation, hyperventilation. So low CO2 levels from overventilation, respiratory alkalosis. I apologize for not picking up that error on my slide review. Respiratory acidosis is sometimes acute if something happens that makes you quit breathing acutely. The partial arterial pressure of CO2 is going to go high, and you're going to have a low pH, and the bicarb is going to be pretty normal, maybe a little elevated, because the increase in the action of carbonic anhydrase on the CO2 dissolved in water thing will cause the bicarb to go up a little bit. But if it's a chronic respiratory acidosis, the pH will come back towards normal. It's the PaCO2 is quite high, but the pH is not as low, and there is an elevated bicarb level because of renal compensation. So the elimination of hydrogen ions by the kidney and the production of more bicarb. Again, this is something that's acute. This is something that has been happening slowly. What are the things that cause acute respiratory acidosis? Probably the most common one these days is a drug-induced respiratory depression. So when somebody is using a sedative drug like a narcotic drug, they decrease breathing and hypoventilate and become acutely acidotic. There are other potential causes. So people who have neuromuscular diseases um, can develop rather acute decrease in breathing, something like Guillain-Barré syndrome, where they develop an ascending paralysis, are unable to breathe effectively. Worsening myasthenia gravis or ALS or muscular dystrophy can also cause hypoventilation acutely. And then airway obstruction related to asthma or an exacerbation of COPD. The chronic causes of respiratory acidosis involve a decrease in responsiveness to those drives that we talked about when we talked about the control of respiration. So, to the hypoxic drive and to the increase in CO2. One of the things that can cause that is a ventilation perfusion mismatch, where we have areas that are being ventilated but not perfused. Um, we can have a decrease in the ability of the diaphragm to work in end stage COPD. And then there are some other things that can cause chronic respiratory acidosis. So, those neuromuscular disorders, again, sometimes there's an acute decrease in breathing, which is leads to an acute respiratory acidosis. But sometimes there's just chronic hypoventilation. The obesity hypoventilation syndrome, called Pickwickian syndrome, can cause chronic respiratory acidosis. And then restrictive respiratory disease like interstitial fibrosis, when we talked about the co-workers pneumoconiosis, or severe scoliosis. If the thorax is unable to expand normally, we have restrictive disease. Respiratory acidosis doesn't do much to serum electrolytes, but it does decrease the amount of calcium that's bound to albumin. So, a lot of the calcium that's circulating in the blood is bound to albumin. Remember that calcium is a cation, and albumin proteins often carry a negative charge. And so, the serum ionized calcium, the unbound calcium, goes up a little bit in acidosis. Remember that in acidemia, acidosis, as hydrogen ions shift into the cells to be buffered intracellularly, potassium shifts out of the cells, but it's usually eliminated by the kidneys, so it doesn't cause clinically significant hyperkalemia. It may go up a little bit, but then if the kidneys are working normally, it will be eliminated to to maintain homeostasis of that ion. It's one of the reasons why when we are treating a patient with metabolic acidosis like diabetic ketoacidosis, it's extremely important to think about their potassium. They may have a perfectly normal potassium level but be depleted in total body potassium and require potassium supplementation fairly early on in treating. Respiratory alkalosis, again, it occurs when alveolar ventilation is high and the CO2 levels go down. It can be acute, so a panic attack. Sometimes it's chronic. And if it's acute, the pH rises and the CO2 is low on a blood gas. But if it's chronic, the pH is closer to normal, but the PCO2 is still low. And the reason the pH returns to close to normal is because of renal compensation, where the kidneys are eliminating more hydrogen ions and making more bicarb The main things that cause respiratory alkalosis are anxiety, hyperventilation syndrome, overventilating with a mechanical ventilator. People with sepsis tend to hyperventilate. Pregnancy is interesting in that there is a physiologic respiratory alkalosis of pregnancy, that pregnant women hyperventilate a little and tend to drop their CO2 levels, but they compensate. Liver failure can cause respiratory alkalosis, and a PE can cause respiratory alkalosis because of the ventilation perfusion mismatch. In a respiratory alkalosis, there are some changes in the electrolytes. So, in respiratory alkalosis, hydrogen ions are going to move out of cells and potassium is going to go into cells. So, your serum potassium goes down. The opposite of what occurs in acidosis for calcium occurs in alkalosis. More of the serum calcium ions bind to albumin. So, you have low free serum calcium. And this is why people who are hyperventilating develop some of the symptoms they develop. They will get paresthesias, numbness or tingling in their extremities and around their mouth. They may get muscle cramps. They may get carpopedal spasm, where the feet spasm at the ankles and the hands spasm at the wrists. And they can get tetany with rigid, cramped muscles. In addition, you might see drops in sodium and chloride. So these are reviews. In metabolic acidosis, the serum bicarb will be low. Normal is about 24, and it's around 24. So a serum bicarb of 18 of 20 suggests this problem. And as we've said, you can have increased acid production. You can have acid ingestion, which are these toxins like acetylsalicylic acid. You can have extra acid metabolic acidosis. You can be reabsorbing extra hydrogen ions or not excreting hydrogen ions appropriately. And you can also lose bicarb from the intestines or from the kidneys. A common cause of metabolic acidosis from the loss of bicarb in the GI tract could be diarrhea. So if you have diarrhea, you lose bicarb. Metabolic alkalosis, the serum bicarb will be above 24. And the causes of metabolic alkalosis include the loss of hydrogen ions either from the stomach or the kidneys, or the retention of excessive bicarb. As I said, metabolic acidosis can be caused by an intrinsic condition like diabetes, or it can be extrinsic from ingested toxins. So if there's a high anion gap, it could be diabetic ketoacidosis, which is intrinsic, chronic kidney disease, which is intrinsic, lactic acidosis, which is intrinsic, or salicylate toxicity, which is extrinsic. A normal anion gap metabolic acidosis could be from the loss of a lot of chloride and bicarb from the gut and diarrhea, and this will result in a hypochloremic, so low chloride metabolic acidosis, also with low potassium, with hypokalemia. There are renal causes. There's something called renal tubular acidosis, in which the renal tubule is unable to appropriately excrete hydrogen ions and potassium ions. And then sometimes, for various reasons, we don't make enough aldosterone. and that can cause a normal anion gap metabolic acidosis. So when you suspect metabolic acidosis, you always take a good history. You always do a good exam. In fact, whenever you see a patient, you take a good history and do a good exam. But the next thing you do is look at your labs. If you suspect an acid-base disorder, it is helpful to get an arterial blood gas, which is called an ABG, and to get at least a basic metabolic panel, which is the panel that includes sodium, potassium, chloride, bicarb, and then kidney function, BUN, and creatinine, and glucose. You need the glucose because if it's 500, it's going to steer you in the direction of thinking about diabetic ketoacidosis. If it is an anion gap metabolic acidosis and the glucose is normal, you have to start thinking of some of those other potential mud piles causes. Look for evidence of renal failure because if the kidneys aren't working, maybe the problem is that they're not excreting hydrogen ions. You always look at the bicarb and you look at the blood sugar. As I said, you compute the anion gap. You have to remember that formula, and you develop a differential diagnosis based on all of those things. Metabolic alkalosis is often first suspected when routine labs show an elevated bicarb. And so it's an increase in bicarb with an elevated pH. And the causes include loss of hydrogen ions from either vomiting or from an NG tube. So sometimes when people are suspected to have a surgical abdomen, we insert a tube into their stomach and pump out the stomach fluids to kind of rest the bowel. And if we're doing that and we're removing a lot of hydrogen ions, we can cause a metabolic alkalosis. When this happens, we need to kind of rethink our treatment. Another thing that can cause metabolic alkalosis is when hydrogen ions move into cells. This can happen also with volume contraction with dehydration if the amount of bicarb is the same, but it's in a smaller total volume. So not taking water in. You can get dehydrated by losing fluids. So diarrhea is dehydration, but in diarrhea you lose bicarb. In volume contraction dehydration from not drinking, the bicarb doesn't go away, so it's in a smaller total volume. And this is an extremely complicated chart, but it allows you to kind of think through what's going on in each of these conditions. If the primary disturbance is metabolic acidosis, and we're starting with a low pH because of excess hydrogen ions, you're going to see also a decrease in bicarb because of the buffering, and you will have a compensatory decrease in CO2 because the lungs are going to try to compensate for the acidosis by getting rid of CO2. This shows you how we compensate. So you will see a decrease in CO2 on the blood gas associated with the decrease in bicarb that you see on the basic metabolic profile. Don't worry about the numbers here, but this will be metabolic acidosis will result in a respiratory compensation. Metabolic alkalosis, elevated pH, there will be an increase in bicarb and then a respiratory compensation that will increase CO2 by decreasing ventilation. So here we increase ventilation, here we decrease ventilation. You only decrease ventilation so much. So this is a limited compensation. In respiratory acidosis, bicarb is going to go up because CO2 goes up and makes more bicarb. If it is chronic, bicarb goes up even more because the kidneys are going to start to compensate and try to make more bicarb. And in respiratory alkalosis, the kidneys are going to compensate again with managing bicarb by decreasing bicarb in the blood and trying to hold on to hydrogen ions. So that's the end of this presentation. I hope it was helpful. I think this is one of the ones that you might want to spend a little bit of time going through more than once. So make sure that you understand the concepts.